Thank you very much. I hope we have an interactive session. We put some common problems what we face every day, but we tend to ignore certain small aspects when we talk in terms of these clinical cases. Let's see how interactive we can make these sessions. Well, the first case VINIAC goes like this. Second-year surgical resident seeks advice from the infection control specialist on specific issues mentioned below following an accidental needle stick injury while handling a hepatitis B positive patient, HBsAg positive, with the following details and investigations. He has been immunized against hepatitis B during his undergraduate course, that is the primary immunization at medical school entry, and a booster dose during internship. And at present, post-injury, his anti-HBs titers were 200 milli-international units per ml. So we just want you to think in terms of whether these antibody titers are protective, because most often what we actually do is we end up, all of us know that we have to be immunized against hepatitis B. We take our hepatitis B shots, we take our booster doses, but we still don't think in terms of monitoring our anti-HBs levels. I mean, if I ask somebody, do you know if you're protected against hepatitis B? I just want to know how many people are going to give me a reply for that. So we just wanted to know with the following levels, whatever we mentioned in this particular case VINIAC, I just want to know if the antibody titers are protective against infection. What do you advise this guy who has come to the infection control specialist?
When antibiotic titer falls below 10 million units per liter.
Yeah, so one thing what we actually wanted to bring out was what is the protective level of antibody titers which need to be there. So it varies anywhere between 10 milli international units to 12 milli international units. So that's one thing which I wanted wanted to stick. So these are the protective levels. But in this particular case, this person has had suppose you put it in another way. Suppose his antibody titers were below the protective levels. What do you think you should? I mean, that's the point we have brought it out. What the protective levels should be. Suppose the protective levels were low, below 10. How would you like to proceed with this particular case? Because if
the protective levels are below 10 or 15 units, he has to take immediately hepatitis B immunoglobulin, followed by hepatitis B vaccination later.
Yeah, so hepatitis B immunoglobulin, the person has to undergo passive immunization, plus he has to have the complete course of hepatitis B vaccine. That's another thing. And next, how are you going to monitor?
Sir, I would like to differ over here. You don't have to immediately give. If you go to a clinician, we have to wait for 6 months at least. Sometimes the virus is destroyed automatically in the blood.
No,
so after the 6 months, usually then the passive immunization.
I'll put it like this. See, if there is a needle stick injury of an infective patient of an hepatitis B, so the basic issue is whether the person is protected by himself or not. See, the moment, suppose he has been not vaccinated at all, so the issue of going for doing these titers doesn't occur. So just do HBsAg. If it's HBsAg negative, immediately is to best to, depending on the load, if it is definitely a 90% chance of infection is high, is to give IV immunoglobulins. You have to give IV immunoglobulins immediately within first 24 hours after the exposure to the hepatitis B infected patients. Even if you give late, the protection chance comes down if it is delayed beyond 72 hours. After 3 days, there is no point in going for immunoglobulins because it's not going to give a protection. So then give a chance to the nature. Nature eliminates, fine. If it doesn't eliminate, then go for whatever the treatment required. So the issue is because the chance of a needle stick injury in a surgical situation like what has been described, it's very high. It's much higher than a HIV infection. The HIV needle stick injury is said to be somewhere approximately around 10% to 25%, depending upon whether it's a bore needle or a non-bore needle, and whether the patient's HIV viral load is high or low. Whereas hepatitis B chance of transfer is very high. It almost comes to 30% to 65%. So that being the chance, it's not worthwhile to take a chance of not giving IV immunoglobulin in this situation if he is not protected. In this particular surgeon, senior resident, since he is protected by himself, by his vaccination which has been previously given, there is no need to give immunoglobulins. So in a sense, the case approach is like this. Accidental injury, exposure to the hepatitis B infection possibility, not protected by vaccine, immediately go for IV immunoglobulins. If patient has been vaccinated before, check whether he is protected by self. If he is protected by self, no further interference required. Not protected by himself by vaccination, go with immunoglobulins, revaccinate. When you revaccinate, please check whether he is a responder. The problem with reference to hepatitis B vaccine is most of the vaccines have a variable responses. See the brand Injirex, which is an imported one, its responsiveness of getting an hepatitis B seroconversion to a protection is said to be in Indian population somewhere between 97% to 98% depending upon the geographic location and various reported things. From the Bharat vaccine, it is little supposed to be higher side. It's between 98% to 99%. See, in a sense, still there is a 1 to 3% of the vaccinated individual who are not protected by vaccine. It is supposed to be because of their genetic determinant to decide to respond or not to respond to vaccines. So that's the reason when a first time an individual gets exposed, check whether he is protected by vaccine. The best way is to do the other way around. Once he gets vaccine, complete the vaccination process, check whether has got a protection by the vaccine or not. Not protected, change the brand, change the different preparation and try vaccinated. In spite of that, a 0.5% may not develop in good immunological response against hepatitis B vaccines.
HbA1c blood transfusion.
He still doesn't require any.
Does it depend upon the viral load? That's what you want to know.
Even see, if you have a responder and if you have a HbS antibody in a titer above 100, 200. So usually when it is above 100, your immune system is geared up and tuned to fight that virus.
So even if whatever the load of blood, yes, nothing will happen.
Nothing is going to happen. Yeah, the other way is to double the dose, change the route of administration, and change the preparation. These are the three ways. In spite of that, I think there is a small percentage who are called non-responders to vaccines. Not that they are immunodeficient. I mean, they are not immunodeficient. So let me be very clear on that.
Chances of getting HIV infection by needle stick is 1 in 300 as per books. But is it redefined, sir?
Pardon?
Chance of getting HIV infection with needle prick is 1 in 300 as per books.
No, depends on bore of the needle, no bore or without bore, amount of viral load of the patient. So it is ranges from 0.3% to 13% depending upon the infectivity of the patient, whether the needle is a bore needle or a blunt needle, and the quantity of the blood it pulls across and the depth to which it pricks.
And it also depends on the HIV viral load of the person from whom you have got the
source case.
Source case.
Is it more with bore needle or without?
It's more with the bore needle because it carries more blood along it actually.
The other thing is need for further doses.
Which mentions that in hepatitis B, if you have an anti-HbS titer above 100 at any time, and even if it goes below 10, you have persisting immunological memory and you don't need a booster at any time. That is what the CDC mentioned about 4 years ago. I don't know if I'm outdated. Is there any new guidelines? If so, can you tell us the answer for these 3 questions and reference for the same?
See, I've just put up a summary. I've just given additional few details as to what is the percentage if the person is HbS-AG positive. The other marker also I've taken into consideration here because we didn't seem to come out with that aspect to see if the person is really infective or not. If the vaccination series is interrupted after the first dose, the second dose should be administered as soon as possible. Here we didn't go into the breakup and think in terms of if the person is vaccinated or whether the doses are interrupted in between. The second and the third doses should be separated by an interval of at least 2 months. If only the third dose is delayed, it should be administered when convenient. Healthcare professionals who have contact with patients or blood and are at ongoing risk for percutaneous injuries should be tested 1 to 2 months after completion of the third dose of vaccination series for the levels of anti-HBs. Persons who do not respond to the primary vaccine series, this point has been raised, should complete a second 3-dose vaccine series or be evaluated to determine if they are HBsAg positive. Revaccinated persons should be retested at the completion of the second vaccine series. Persons who do not respond to an initial 3-dose vaccine, this is again I think I've already mentioned, persons who prove to be HBsAg positive should be counseled regarding how to prevent transmission to others and regarding the need for medical evaluation. Non-responders to vaccination who are HBsAg negative should be considered susceptible to HBV infection and should be counseled regarding precautions to prevent HBV and the need to obtain the immunoglobulin prophylaxis. Booster doses of hepatitis B vaccine are usually not necessary, and periodic serological testing to monitor antibody concentrations after completion of the vaccine series is not recommended. This is just an information. In studies of healthcare professionals who sustained injuries from needle stick contaminated with blood containing HBV, the risk of developing clinical hepatitis if the blood was both hepatitis B surface antigen positive was about 22% to 31%, and by comparison the risk of developing clinical hepatitis from the needle contaminated with the HBsAg positive, HBeAg negative blood was only 1% to 6%. So another thing which we probably need to do on this patient who was HBsAg positive is to look at the HBe levels, to look at the infectivity rate, because this gives you some amount of information as to the rates of transmission. This point we thought somebody would raise and say how infective is this person with HBsAg positivity.
Sir, I want a small clarification regarding in spite of 3 doses of hepatitis B vaccine.
Yes.
He mentioned about responders and non-responders. When we give 3 doses, we generally take it for granted that the antibody levels have sufficiently raised and is fully protected. We take it for granted. We don't normally test the antibody titers. So I want the clarification for responders and non-responders. Is it really necessary to do the antibody levels? One second. Antibody levels after 3 doses. And number 2, he said booster doses are not necessary. That looks like that holds good for the general public. Whereas for doctors, every 5 years, 4 to 5 years, we need a booster doses to be continued as long as we continue in the medical profession. That is what I believe. I want your comments.
See, regarding the responders and non-responders, to differentiate, it is always worthwhile, especially the health professionals, to undergo a check for their levels of anti-HBsAg antibodies. The basic reason is, see, as we put it, see, there is a very high risk. The persons who work with a high risk professional to get an HBsAg infection are the one who need to be little more protected against these viruses rather than the common population. So that's the reason there is some dividing in the opinion, as one of the delegates said actually. CDC recommends no repetition of the boosters, but it's for the general population recommendation. With reference to health professionals, especially the health professionals placed in Oriental as well as in the Saudi areas where hepatitis B infection is high, there they recommend every 5 years to take a booster dose. The reason attributed is the possibility of they landing up with one or the other prick is very high, since they are likely to be exposed to these patients being on the higher side. And the protection is always much safer and better if already preformed antibodies are more, rather than there is a lag time wherein it's always a possibility the virus can go and land into the virus. Once it gets into the hepatocytes, the way the virus need to be eliminated is totally different from a way a vaccine could protect. So there is a little difference in this particular place. So that's the reason theoretically most of us believe, and most of the recommendation believes, that the people who have a high chance or high risk need to go for repeated boosters. But there is still a divided opinion. Some say still you cannot, but it holds to American where the hepatitis B infection rate is considerably lower compared to the Oriental as well as the Southeast Asian population.
Does it have 100% protection?
That's what, sir. This is just a hypothetical situation where we say this is a protective level. That is what the very reason why we put up this case was to first start thinking in terms of, like we are talking in terms of immunization and we say this is a protective level. But you never go and counter check whether this, unless an exposure really takes place and unless a person presents either with serological evidence or clinical hepatitis, it is difficult for you to really tell whether.
Is there any case reports of particularly renal dialysis after the vaccination and documentation of adequate antibody? Is there any reported case of hepatitis B? No.
I have only seen literature which says the usual schedule of hepatitis B vaccination, you have protective antibody titers lasting up to 10 years, which is, patients do have titers of more than 200 to 300 milli international units per ml even after 10 years after you've taken the primary immunization and your booster doses. So there are a lot of studies saying that these are the levels of anti-HBs after 10 years after which a person has finished the immunization schedule, but nobody talks in terms of people getting infection, having been immunized against hepatitis B. In fact, we brought this up because this is an issue which we very frequently don't think in terms of.
There are there are few gray areas. I think we need to look seriously because I think, as I said, most of us what we do is we get vaccinated. We never cross-check whether we are protected or not. The best way is take the total vaccine, check for the protection levels, and based on the protection level, one can seriously reconsider about what to do next. So if there is no adequate protection level has come after completion of the vaccine, you need to go for rescheduling or going for a change over the preparations or double the dose and take it. So try to get a protection level and subsequently things go fine as we are expected. See, the problem in any vaccinology, any vaccine is it's not always 100% protective, it's 95% protective. That's a fair enough chance to take in life. And the other issue was the guidelines is what it stands right now like that. So is take a vaccine, check for it, which most of us don't do. We just take a vaccine, as you said, we presume we have taken three doses and well we are protected. Once in 5 years go with repeated boosters. That's how most of us are managing. But the best practical way, especially for the health professionals who are likely to have a high risk of exposure, to cross-check and manage it further.
We go to the second case, Vinayak. A 30-year-old healthcare worker was diagnosed as being HIV positive following occupational exposure, has recently delivered a healthy female child 2 days back. The ELISA test report of the child is positive. The mother is in panic about the HIV status of her child. How do you proceed with this case?
Yeah, here I think the mother need not panic over here. The first thing what we have to advise the mother is to stop the breastfeed, because there is statistical data that the virus does spread through the mother's breast milk, and usually the child becomes 80% of the children in this particular group, they become negative after 4 or 5 months. So this is the usual awareness we have to get the mother into.
What will you do to know whether the child has been infected with HIV or not? That also you have to worry about. So
initially, yeah, the HIV.
You have to stop breastfeed, exactly. That's absolutely right. In addition
after
to that,
4 months, we have to again recheck whether the.
You can't wait.
I have a small thing. Suppose the child is already HIV infected, there is no point in stopping mother feeding the child and child enjoying the mother's cozy feeding.
Exactly. No, not RNA, probably pro-viral DNA PCR. A qualitative DNA PCR would help initially in picking up the infection.
What we actually wanted to summarize here was children born to HIV positive mothers may have false positive test results for several months because the mother passes on the antibodies to their newborn children. Even if the children are not infected with HIV, they have HIV antibodies and will test positive. Other tests such as viral load test must be used. The first test should be done soon after birth, preferably during the first week of life, Then the next, the follow-up PCR can be recommended after about 4 months. The PCR method uses an enzyme to multiply the HIV in the blood sample. Where there are 3 methods. Then a chemical reaction marks the virus. The markers are measured and used to calculate the amount of virus. The other one is the branch chain DNA assay and the NASPA. The first DNA test, branch chain DNA test was done, which could measure up to 10,000 copies if it was present, but the present DNA test, quantification of HIV DNA using a PCR assay, is the one which allows early diagnosis of HIV infection in infants born to seropositive mothers. So the information what we wanted to drive in is just think in terms of quantitation HIV DNA PCR for detection of
Here 2 things we would like to point out. See, one is it is not appropriate for the treating team to use ELISA as a method to confirm or not to confirm whether the child is HIV infected or not. It creates an unnecessary panic than what it is, because the chance of a child born to a HIV infected mother having an HIV positive by ELISA method is almost 90 to 95%. So it's unnecessarily create a more a panic rather than clarity on the issues. So the best is to go for either by a PCR method to check whether the child is infected. If it is not infected, as you said, try all the isolation method to get the child out of a possible infection. If the child is infected, well, so there is no point in allowing both mother and the child to suffer from what others mother and child bonding is of breastfeeding continues. So the best way is to make clear at that point by this technique rather than going on immunoglobulin based assays. If you remember the previous case of immunodeficiency, we made point clear, we drove the message clear that first 4 months, because of the transmitted immunoglobulin from mother to child through placenta, it protects and also can give a false positive results in quite some of the tests for which mother could be positive. So the same thing is carried forward here.
Even the P24 antigen assay will not be useful.
In the same child, ELISA positive, you suggested, Dr. Chandrasekhar suggested we to go for PCR, but I want to know what exactly is the difference between PCR and we do the Western blot also for confirmation.
See,
what is the difference? What is the difference and which is superior?
Western blot is basically an antibody assay. See, antibody assays are the ELISA methods as well as the Western blot. In ELISA, only thing is it's a mixture of antibodies which are coated onto the wells, whereas in a Western blot, these antigens, they are separated out by electrophoresis, and then later on the blotting is done, and then you try to see which specific antibody is present. That is what we do in a Western blot. So both Western blot and ELISA are antibody based assays, and these assays are the ones which we very commonly use, but these all have a very long window period of 4 to 6 weeks, at least 2 months. So that is why now we are actually going in for assays which are called as 4th generation assays, which include P24 antigen assays, wherein you also try to detect the P24 antigen as well as the antibodies. Look for the presence of both. So that is what we are doing, and these are antibody based assays, whereas these are direct assays where you are looking into the quality or a quantification of the virus as such. When a virus attacks the host cell, the human cell, first it will go and internalize itself and forms a proviral DNA, and that's the one time when you pick it up at the earliest actually. So that's why we say it's better to go in for a proviral DNA PCR or a qualitative PCR at that effect.
You mean to say PCR test can immediately detect the virus?
Yes, within it can pick up as early as 24 to 36 hours.
And what about Western blot and ELISA? How much time?
Sir, again, like Madam clarified, I'll just tell you, I'll try to make it easier. What we do in ELISA is you have a whole antigen which is there in the well, and you try to detect if there is an antibody in the patient sample or not. In Western blot, what is done is the whole viral particle is broken down into its components, the outer envelope or the inner part, or it's just broken down, and those broken parts are electrophoresed onto a paper, and that is what is used as a strip. And when you have this patient sample again it only gives you information whether the patient's sample has antibodies against these individual components. That's what we are Western blotting. So again, it is just antibody based. So it's always better, to detect the agent itself rather than thinking in terms of detecting, the antibody against the particular agent. So what PCR does is it actually amplifies, even if there are smaller amounts of agent in the sample. But again, the only drawback of this particular thing is, what I'm trying to say is, just to have it at the back of our mind, that what we take as a sample, is your blood, and only 2% of your virus is going to be there in your circulation, and we really cannot think in terms of the virus if it's sitting in somewhere in the tissues, because each time what comes into circulation is only about 2% of the virus. That's the only thing. But otherwise, it's a very good tool we have for detection of infection.
Yeah, every assay has its limitations. As you said, we have so much amount of volume of the blood, and if the virus is not there in that, then we will not be able to pick it up. But if the load is very low.
That's the reason, I think, if you see the recommendation, is said to do once at the birth and to repeat it after 4 months. So just to repeat again to double.
At that time, once you do it later, then you can do an antibody assay or an antigen assay. The PCR, a qualitative PCR costs somewhere around 1,500 rupees, whereas a Western blot also costs around 1,200 or 1,500 rupees. So the cost difference is not really much. It's only thing is when we do a routine screening, see what happens is this qualitative PCR assays and all are not to be used. They have not much role in routine screening. In adult population, actually it has no role at all. It is only when we are talking about neonates that we go in for a PCR assay. So actually, ideally in a routine screening, what we use is either an antibody based assay or an antigen based assay. Unless, yes, sometimes some of our fellow clinicians or surgeons, sometimes they suddenly have a prick and they are so worried about it. There are times when we have done antigen assays also, we have done quality PCRs and all that, just so that they are at peace that there is no problem after they have a needle prick injury with HIV positive patient on such cases. But otherwise, no.
The blood banks, the blood collected, no, they are not doing the PCR test, they are doing only the regular test.
No.
Suppose if the blood from the patient donor, suppose if he is in the window period, there is every chance it can carry the viruses.
That is why to bring down the window period.
That is the risk involved.
I'll answer your questions. See, the problem is this. See, there is a change in legislation in United States and other part of the world. Now every blood transfusion has to go through PCR method for both HIV, HCV and HBsAg. But if that legislation is brought to India, the problem what the administrators are worried and are thinking is, now with the HIV, HCV and HBsAg by ELISA being made compulsory, the cost of the one blood unit has come to 650 rupees. If they introduce PCR for all the three, the cost is going to be per unit approximately 4,500 rupees. So that's where the Indian administrative units sat several times, but finally took a decision that in the larger interest, this is the only thing what we can do, and we have stopped there.
So that means to say we have made a compromise.
We have made a compromise.
We have made a compromise and allowing HIV to spread.
We have
that's in the window period.
See, now the problem is the problem is for that sake, what rule has been made, but unfortunately it is not followed by the commercial banks. The rule that has been made is to only go for replacement donors. They insist the relatives to bring their donors and to donate and get the replacement out of it. That is done with a simple contention that it is expected the relative to bring who he suspect them not to have these kind of problems. So that's the reason why we are trying to move away from the voluntary donors or the donors for any commercial nature. But unfortunately, what I see in the practice in a larger side, still the commercial banks, still the blood banks which doesn't practice these rules and regulation and safety norms in an appropriate way are encouraged for a variety of reasons. I know the reasons, I know the problems, every one of us know about it, but still we are not able to fight with us.
Sir, but of late, most of the good blood banks, like many of the institutions, they have got a questionnaire where every donor has to answer and they ask for an exposure history or any previous blood
But that is as a protocol in every blood bank.
Protocol.
We have to have a question.
But they don't follow that in a group donations, like where there is a, for example, Lions group is organizing for a blood donation where some 30-40 people are coming, students. They can't ask that same protocol to be followed there. But they are doing it now in institutions and many of the good TTK blood banks and all, wherever they go, they have to fill this questionnaire. If they don't fill, they are not allowed to donate.
No, most of the institutions, they ask for questions.
We are, as you said, we are trying to follow some cheaper method to circumvent that. But of course, as you said, there is a risk. But as you said, we need also have to seriously work on that. See, you might have seen some of the patients with 600 rupees, 650 rupees to get 5-6 units. They will be fighting around. They will be really running around to garner that money. So it's a tough call if I ask for everything to be done by PCR.
After collection of the blood from the donors, I do the test, and if the test is positive for any of these infections,
Then
they
we
discard
discard
it.
it. We discard.
His concern is a window period. His concern is clear.
No, window period is not 6 months now, because basically now they are introducing the fourth generation ELISAs with P24 antigen, which is becoming compulsory slowly. And that will bring down the window period to a few weeks actually, instead of months.
We take up the case Vinayak 3. A 22-year-old man presented to the chest clinic in a teaching hospital with bilateral pleural effusion. The physician wanted to rule out tuberculosis after clinical examination. The following investigations were done. Zn stain on the sputum specimen, negative for AFB. ESR moderately high. A MAN2 test, induration of 12 millimeters. Culture for mycobacteria, results awaited. TB quantiferon gold assay is positive. ELISA for tuberculosis, IgG positive with high titers, IgM negative. How do you proceed with this case?
Diagnostic phototaping and analysis.
Fine, sir. With the, apart from that, like what analysis would you like to go in for, sir?
Oral analysis for protein, sugar and
Fine. Sir, you already have some other investigations here. Would you like to make comments on that, using that?
I do not know about the reliability of TB quantification, otherwise other things are
Would you like to comment on your MAN2 test, sir?
Pleural biopsy, CT guided pleural biopsy with assay for tuberculosis.
See, the first point actually what sir brought out was, he said, I know about most of the investigations except TB quantiferon gold assay. I do not know much about it. This is exactly what he was saying, and that's exactly what we wanted, because a lot of times you have people asking for this assay now, and people do not know about the utility of this particular assay. So we thought, yeah, we yes.
This TB quantification gold assay is for latent infection.
Yeah, see, this is one thing, like agreed, this is able to pick up latent infection. We just trying to tell you about the utility of this particular test.
Can we go for PCR?
Yeah, yeah.
No, PCR from where?
PCR, yes, but
Blood.
from where, sir?
Blood.
PCR from blood will not help you. PCR from pleural fluid is a welcomeable suggestion. One is a pleural biopsy or a pleural effusion analysis, as doctor said, or other possibility is go for a PCR from the pleural tissue. All negative. Pardon? No, actually, if the patient walks to your clinic with this much of information, now where do you go?
You might end up treating the test and not the patient.
Because what I'm trying to tell you is, this is how the patient walks into our clinic. The patient comes with every test done. So now we go about.
Even if the patient is a tuberculosis patient, he is not in a contagious stage, so it's not an emergency to treat such patients. So we can wait for a bronchus to open if at all he's got a cavity going on, cavitatory process going on in his lung. Or if it is a hematogenous spread where it is only caused the pleural effusion, the best thing is do a pleural analysis first. If that shows anything, or a PCR of that shows anything, then categorize the patient according to the treatment schedule, then treat him. Otherwise, we can just wait for some more time in case a bronchus can open up in his lung.
Problem is, he has a bilateral pleural effusion compromising on.
Yeah, then the only thing is you have to go for a pleural effusion analysis and a PCR of the pleural effusion.
Okay.
Yeah, going in for a PCR would be the ultimate thing, I do understand, but what I'm trying to tell you is like, what would you infer from this, test result of your TB quantiferon gold assay which you already have?
The inference would be the patient has been exposed to tuberculosis in the past. That's all, nothing more, nothing less.
Exactly.
Yeah, so like here we have specifically told that man2 has an millimeter which is borderline positive, and you have your TB quantiferon gold assay which is positive.
Patient is positive for latent tuberculosis. Doesn't prove that this has got the effusion is due to that. So you have to independently work for the cause for bilateral pleural effusion. You cannot act based on this test and treat them on ITT.
Exactly.
Even if the patient comes like this, the basic thing is the categorization of the patient according to the present RNTCP program into the DOTS regime. So we can never do it with this particular investigation approach at all. Because each thing will be different. If at all it is the same thing, 1 second, so if the same thing, if the effusion comes positive, he might go into the second category. If it's a pulmonary tuberculosis, he might go into the category 1, where the drugs, the duration also differs and the number of drugs differ. So there it will be a problem in case we take him less. So best thing is to wait or do the pleural effusion analysis. As Dr. Dharmanand rightly pointed out, it is a latent, maybe pure previously, or he's exposed to other person in his family or in his neighborhood, because of which he's got a subclinical transmission.
You cannot now call it.
Sir, another useful thing is after a good tapping, we have to repeat one more chest X-ray which may give some more details about the lung parenchyma. If there is any other pathology in the lung parenchyma like cavity or any other evidence of tuberculosis that confirms it radiologically. So tapping and redo an X-ray is quite useful.
Yeah, finally we do agree that your clinical examination, chest X-ray and your pleural fluid sent for PCR would be the final thing. Okay, and this result, so what actually your test quantiferon says is only, it can be used only for evaluation of tuberculosis and say whether it is active or latent. And here actually what is done is you have tubes which are coated with antigens, to which you're going to add the patient's blood specimen, and if there are the lymphocytes are actually only going to produce interferons specifically to mycobacterial antigens, mycobacterium tuberculosis antigens. It just gives you information that the patient has a possibility of exposure to tubercle antigen. But what I would like to impress here as far as the test is concerned is it's a better option compared to your man2 test, which can be influenced by prior exposure to the test, or when you repeat the test the induration could go up, or the measurement of induration by individuals could vary between people, whereas that is not going to be there in this particular case, because your BCG vaccination has no effect on this particular test, and only in very rare cases of atypical mycobacteria you can get a positivity with this. So it is, I agree that the final thing what you would like to do is a PCR with your pleural fluid, but what I am trying to tell you is that TB quantiferon assay is a better test to do rather than going in for your man2, for exposure against tuberculosis, because your man2 is going to give you false positives because of prior exposure to your BCG, whereas that is not going to be the case with TB quantiferon assay.
Actually, I'll just have a small comment.
Sir, give the information about active infection presently or a latent infection.
Sir, here actually
it doesn't give any information whether it is active. It just indicates that the patient has been exposed to mycobacterial infection.
If a patient is exposed 10 years ago for a tuberculosis infection, it will, then also it will be positive.
And also it could be positive if the bacterial multiplication is there. Now I think actually why we brought this case was like this, because this is one of the way which we sometimes see the patients coming into our opinion for a second reference, because usually at this point they suspect either query SLE or query other connective tissue disease and send for an opinion. See, there are some logic way to work out here. Actually we have a lot of available tests for making the diagnosis of tuberculosis. Half of them are confusing, 90% of them time are misused, and we are still unable to come to a conclusion, to a point whether we should treat this patient with anti-tubercular or not. See, I am not getting into the DOTS classification because there are certain limitations in the DOTS classification, because DOTS classification is trying to work with the epidemiology as well as to treat the larger mass. So when it comes to individual case by case, sometimes you may not be either able to put them into either of the classes. What I am trying to say is, in this patient, he has a bilateral pleural effusion, no cardiac cause, no nephrological causes, no other causes to explain the bilateral pleural effusion. It's an inflammatory effusion as per the fluid tap analysis which suggests, and of course the PCR was not sent at that point of time, and what they had done is Monto was 12 millimeter, borderline inconclusive, nothing was done. Then blood for PCR is not a test to be done, because blood for PCR will never happen positive with an exceptionally rare patient of disseminated tuberculosis. Otherwise mycobacteria will not be in blood circulation. So never ever send blood for PCR when you are suspecting tuberculosis in some corner like a pleural fluid or even in any other site. It's not going to help you at all. So the best is to do a PCR if at all you want, or if you are seriously considering the diagnosis, is to tap the pleural fluid and send pleural fluid for PCR. So even there is a possibility of missing it from the picking up the tubercular bacteria by PCR. So here what I am trying to say is, suppose ANA is negative, complements normal, everything else is negative, still it's an inflammatory fluid. Now the biggest question remains is it a transient, other causes of recurrent pleural effusion versus tuberculosis? So now that's the case, that's being the case, since it's only a pleural effusion, you can wait for a couple of weeks or months with a non-steroidal anti-inflammatory drug, watch for some time. If it doesn't disappear, retap again, reanalyze. If you find again negative, best to treat them as with anti-tubercular drug, because you have some subtle proof to say that the patient have been exposed to tubercular bacteria sometime, and some amount of activation or reactivation is going on with reference to him. See, this is not a hardcore proof to say yes, it is tuberculosis, but you do face this kind of clinical scenario quite frequently, especially in a special reference center like this. So what we do at this point is like this. So we do most of these tests, most of these are negative, watch for a couple of weeks or months with NSAIDs, doesn't recede at all. After trying to tap the fluid, re-get the chest X-ray is normal, reaccumulates again, workup for malignancy is negative, everything is negative, still goes on reaccumulating. Usually we find if quanti-gold is there, normally we try to treat them with ATT. I have a series of these kind of patients where we have tried with anti-tubercular empirically based on these tests. Out of 20 patients which I have, 10 to 12 of them have responded to this. So probably it's a 50-50 as per the statistics, but number is too small. I think maybe once I get still more number, I will come out with the entire publications.
Yes.
PCR could be positive even with dead bacteria. And how do you think PCR is?
Sir, sir, you have RT-PCRs which you can do, which will only show your positivity if there are live bacteria. You have modifications wherein only live bacteria is going to multiply.
What is that modification?
RT-PCR, sir. It's RT-PCR.
Real-time PCRs.
RT-PCR is.
That also you
What
have
does
RNA.
it cost?
Costing of TB-PCR I'm not.
In a clinical situation like this, I
What
agree
we are
with you.
having is around 1,000.
It is always a place for a therapeutic trial. I think so far as this country is concerned, I don't go on for all this IgG, IgM and all that. It is going to be positive. If it is negative, not helpful. If it is positive, not helpful. So in these cases, if you exclude other causes of bilateral effusion, preferably I would go for a therapeutic trial with ATT and watch for this. I think that is the most practical way of dealing with it. It is an accepted way.
Somebody has said that it is just a glorified Mantu.
Exactly.
So that is
exactly.
No,
but it's the same thing. It's a glorified Monto. Only thing is here it's more objective rather than the subjective thing that we take in a Monto, and it has to be read well, given well. It has to be injected appropriately the measurements have to be taken only in a vertical direction. All those things have to be followed when we do a Monto, which we are not able to monitor most of the time, because when a tuberculin skin test is done, half of the time most it's the technical staff who do this assay, and sometimes they are not really up to the thing to read that actually. The induration alone.
What happens if it is a BCG vaccination? Does it make a difference in both the tests?
with quantiferon doesn't get
Quantiferon
affected
give you
by
a
the
negative.
BCG vaccination, but whereas the tuberculin skin test, the MON2,
Yeah.
it does get affected by BCG vaccination. So it has its some advantages. Yes,
It
yes,
is
sir.
bet-
Definitely it has one advantage.
12 millimeters of manto result here, this particular patient, 12 millimeter manto
it's
positivity
not,
does not give any weightage
it doesn't
in
give
making the
any,
diagnosis.
yes,
Only
exactly.
if it is a very strong manto, something like about 20-25 millimeters, induration, ulceration, only
Right,
then it carries
right.
some weightage. Otherwise,
Because we
this
have to take
manto
only
becomes a
induration.
totally useless test in this
Absolutely.
particular patient.
Right.
Doesn't help.
Right.
Okay, the next case is a 22-year-old young boy, smoker since 1 to 2 years, presented with bluish discoloration of fingers with severe excruciating pain. There is no change in color with temperature. On examination, the patient is afebrile, no constitutional feature, all peripheral arteries felt. Other systems normal. Hemoglobin 15.5 grams, total count 6,500 cells per cubic millimeter, differential polymorph 68, lymphocytes 30, eosinophils 2, platelet count of 2.5 lakhs, LFT, RFT and urine routine are normal, arterial Doppler and echo normal, ANA positive 1 plus, speckled, ANA profile is negative, complement 3 and 4 normal, ANCA is negative. What is the next best test?
So in this case, we suspect primary antiphospholipid antibody syndrome. So we do anti-cardiolipin antibody and lupus anticoagulant. The next possibility is cryoglobulinemia. So we do cryoglobulinemia and we suspect associated with the hepatitis B and C infection also. We do viral markers. And regarding treatment, we consider for methylprednisolone. If viral markers are positive, we consider antiviral drugs.
Exactly. Is
Yeah,
it the
you are
absolutely
bullseye.
yes answered?
That's good. I think
Which he did,
the most important thing we need to remember is this. Actually, whether young or old, a patient whom you suspect a possibility of vasculitis, if a possibility of vasculitis workup are negative, and you think it's still there could be a possibility of a thrombotic event. Here I have made a mention that Doppler was normal, but you need to remember the Doppler picks up only the large vessels. The small vessel also can go for thrombosis. Antiphospholipid antibody, not just that it clots in large vessel, it can clot even in the microcirculation and can cause infarcts and gangrene. So what it looks like is a possibility of an antiphospholipid antibody syndrome where it is a lupus anticoagulant which turned out to be positive. Why this differentiation is critical? Because the treatment lines are absolutely different. What you manage here is the anticoagulation and not immunosuppressions. Immunosuppressions are not going to help, though not cause harm, but it's not really going to help. So immunosuppression is not like an antitubercular therapeutic challenge because immunosuppression should be thought of before you put it. Whereas oral anticoagulant has to be looked in. But if you are not able to decide in certain set of point, because sometime in some places getting APLA workup there may be a delay. You may have 2 or 3 days. Best is start them on low molecular weight heparin when you feel that connective tissue disease workup, vasculitis workup are negative. Because I do understand that not that all cities and every hospital can get APLA workup like as we could get. We can get normally within 24 hours. And we can take a call whether to go with oral anticoagulant or anticoagulation or not. If there is a time delay, if you suspect it could be possibly thrombotic, there is no harm in giving 2 doses or 3 doses of low molecular weight heparin for a couple of days, even if it happens to be vasculitis. There is some studies, very anecdotal observation which says that using some little of anticoagulation can help even in vasculitis patients because platelets which are active, thrombotic activities is active even in vasculitis can be reversed if you early use anticoagulation. So you are not going to cause harm to the patient. You very well, if you are waiting for the diagnosis, an early introduction of OAC can restrict the area of infarct.
So we end the care series here.
Yeah.
Facility is not available. Would a D-dimer, would that rule out a syndrome, or if it is very high?
At least if a PTT was done and by chance a PTT was prolonged, that could have given them
The
some
PTT
direction
prolongation
to
can give a
work it
hint.
onto the APLA workup.
Hint, otherwise if it's available for a D-dimer.
No, D-dimer since the thrombosis is too small may not be elevated. because the thrombosis, what you are expecting is a microthrombi. So it's in only 2 digits. We don't expect D-dimer to be much higher value, maybe maximum, maybe 100 units or 10% rise. It's always a question mark.
So a negative D-dimer here would not confidently rule out an ongoing thrombotic process.
Yes.
So one more question, even though it's out of the way question, I would like to confirm it. Suppose many patients, they would like to try, for rheumatoid arthritis, they would like to try Ayurvedic treatment or homeopathy treatment. They come to us, they ask the question, shall we continue that or not? One question. Second question, shall we combine your allopathy with the homeopathy and Ayurvedic? So what you do, Sir Chandrasekhar? The patient comes with those questions, what exactly you answer them or we exactly manage them?
See, with reference to vasculitis, systemic lupus erythematosus and all other connective tissue disease, I make point blank clear that if you are going with your risk. And I will make a note and you can take a consent and do whatever it is, because these diseases we cannot take risk with any alternative or any other medications. With reference to rheumatoid arthritis, as Dr. Dharmanand was telling, see, there is always a resistance from the patients when we talk of disease modifying anti-rheumatic drug, because somebody has already primed them saying that methotrexate, anti-cancer drug, azathioprine, some other name, steroid, there is some other things. So because there is some confusion there, but you need to technically handle it. As Dr. Vinuta presented in her first lecture, she made it point clear. Earlier we intervene with rheumatoid arthritis with disease modifying anti-rheumatic drug, success rate is very high. So they experimenting for a couple of months or couple of years and come back to you, what was in category 1, that is early arthritis, you would have gone into a late arthritis where you need to use multiple drugs rather than 1 or 2 drugs. These points should be told to patient clear, but in spite of that, in rheumatoid arthritis, sometimes I say, okay, it's up to you. I don't say much more than this. But when it comes to other than rheumatoid arthritis, especially connective tissue disease and vasculitis, I warn with the straight word, if they don't understand, you are risking yourself, your life and your wife with these particular problems. It's up to you and take a decision on that, because that hard word is required sometime to tell them or convince them.
You feel Ayurvedic and other allied subjects don't help much in rheumatoid arthritis especially?
Not without a DMRs. You can use DMRs, but I am always little skeptical to combine other drugs, herbal and non-herbal, homeopathic, because the reason is we really do not know the drug interactions. I really do not know what alkaloids they have. See, I am 100% sure they have active principles. It's not that they are without active principles. Myself have worked in 2 or 3 of the herbal preparations with reference to allergic when I was in MS Ramaya. We have done in vitro test with reference to those extracts. They really do an alteration in cytokine profiling in lymphocytes. They do stimulate lymphocytes. They do alter the immunological systems pretty well. It's not that they don't do anything at all. They do it. But the question is how sensibly it is used matters. But what really happens is we really do not know what it does, and we know what this does. So when what is this does with another unknown factor, the end result when it is unknown, we are in a confusion. So it's best to avoid those combinations.
Tell the patient strongly that you better go with allopathy treatment only. Thank you, sir.
If I can add to this comment, this is a very, very common problem. Almost every patient asks this. And rather than being like in a connective tissue disease, vasculitis, who is having a gangrene and renal failure, better to be blunt. Right? Disease is like this, a life-threatening disease. If you want to take a risk, it's your own risk. You can do whatever you want. But in a rheumatoid patient, it is better to be little more considerate, because they have been torn by 100 inputs from many sources. So we have to probably give them upfront what is known in this alternative medicines. There are few certain alternative medicines, so-called alternative system, which are absolutely safe. Somebody wants to try a Reiki, somebody wants to try yoga, right? You can always encourage them, that doesn't matter. But if they want to try Ayurvedic, Unani, particularly these 2, this contains active principles and they can do harm as well. If you ask a nephrologist, they would say that we have seen a lot of patients with renal failure with these drugs. We have seen a lot of patients who have pulmonary hepatic failure with Unani drugs. They are not absolutely safe drug as claimed to be. So interactions are very unpredictable. So we have to tell the patients that, okay, you have a disease, the first 3-4 months is crucial for our treatment. If you still want to try for a few months. If you don't get better, and within 3-4 months, get back to us, we are ready to see. See, what happens is, if you say, do whatever you want, don't come back. If you shout and send them off, they are always scared to come back. Say, I would, even if they try, say, I have seen my patients seen by me 2002. They have gone back to Ayurvedic, come back to me on 2004, still we can do a decent job. If I have been very angry at the time and very irritated, they are scared to come back. If they don't come back to either me or Chandrasekhar or a rheumatologist or somebody who treats rheumatic diseases, they will still keep on in the circle. They will try homeopathic, another Ayurvedic, another Ayurvedic. Under 10-15 years, they will come in a wheelchair. That is much more bad. So, give them a chance. Give them, these are the choices, what it can do, what is the scientific evidence in homeopathic. There is some literature, minimum effect can be there. Ayurvedic, there is some minimum effect. But this is the best available treatment. If you want to try it for a few months. If you don't get back, come back to us, I am there. So if you tell that, probably patient will come back to us when after they have tried what they want to try.
Yes, sir. So just to add to this, as doctor has rightly pointed out, many of this Ayurvedic and homeopathic components nowadays, there's a research which has been done by rationalists and all, they found that a lot of heavy metals have been added to this, lead and mercury especially. So lead, you do so acute porphyrias. I want to just quote one particular case of mine, where this girl was asthmatic. I told her 2 years back she is asthmatic. So this is all your treatment is with inhalations and all the aerosols. But unfortunately, this girl was taking Ayurvedic medicine and she came back after 2 years with stomach pain. And she was investigated by the best gastroenterologists in Bangalore also. They couldn't make out. Ultimately, they were going for a diagnostic laparoscopy. And one of them suggested for a laparotomy also. One of them had already removed her appendix. So ultimately, they came back to me because I was her family physician. And I just asked her a simple question, have you been taking any other treatment apart from allopathic treatment? She told that she has been subjected to some Ayurvedic medicines in Majestic area. She's been on it for last 2 years. And after 1 year of time, she started developing this abdominal pain. So back came the diagnosis. It was just porphyria, which was because of lead intoxication. When I checked the serum blood levels, it was sky high. And we just put her on penicillin. She recovered without any surgical intervention. So lead and mercury is a very important component of most of the Ayurvedic and homeopathic drugs, which many of allopathic doctors are becoming aware of late. And these are one of the components which do cause nephritis as well as lot of gastrointestinal damage.
Yeah, sure.
The American insurance has reimbursement to homeopathy. So after that famous Lancet quoting saying that homeopathy is no better than placebo, people practicing homeopathy. And the number 2 thing I would like to quote is the quote given by the Nobel Prize winners last year, olfactory, I forgot, but those people, neurologists and the neuroscientists who had worked, they were asked how was it, and they said that, I don't remember the name of the lady, but she said that I had a thought 25 years back and I stuck to it. I think we have to in our mind that it is immense injustice to scientists working all these years to try to prove in modern day science, and we have to go by evidence. First, we have to be convinced that these things which don't have evidence should not be really encouraged in any way. You have proper trials in homeopathy and Ayurvedic. You be a part of trial, try to prove that. I was a part of a trial of a company and of an Ayurvedic drug because I first said no, and then they said, who else will do this trial? I said fine, because the Chinese are coming out with the Chinese drugs, which are all basically herbal drugs. That trial, of course, was as good as placebo as was expected. There was a huge hue and cry, and there were so many pressures to make the trial work better, but it was not better than placebo. So until we have that kind of data, I think we have to be very convinced that we cannot allow such lack of evidence-based things, because it is also injustice to those people who have been working for all these years, trying to prove just such a small thing. So first we have to be convinced, and of course telling patients is another thing, because we have to be convinced ourselves. I think many of us are not convinced, and if I were to get rheumatoid, I have doctor friends who go to homeopathy for their own cure. So, I mean, they go, they are allopaths and they are practicing. So they are not convinced. Out of frustration they go, but I think we have to be very convinced that you can't go by anything that doesn't have evidence in today's, and you be a part of evidence and try to prove it. So first we have to be convinced. Telling patients is another thing, because as Dharman said, yeah, sometimes we cannot be very rude to them. So I tell all my patients that it is injustice to the scientist who's been working for 30 years trying to prove a small thing, and he may not still prove it and he dies. So I think that is very important. And then you tell them that they still want to take, they take. You cannot be harsh to them, very true. But I think first we have to be convinced that these things don't work. And if they work, we have to prove it. As he said, if we could go further on those trials, I'm sure there must be something. And we'll do our country proud by bringing out such a drug in a proper form.
I just put see one other reason why I'm carrying out with these CMEs and all those things is the same thing. When I came in 1996 and started my 97 when I started that, the first thing I did when I joined MS Ramaya was to send a survey to all the general practitioners as well as few of the post-MD practitioners from MS Ramaya with a small simple questionnaires carrying 18 questions. The questions were simple. The first question asked that, how many different type of arthritis do you know? 1, 2, 10, 110. So like that. And there was few questions on alternative medicine. Do you think the modern medical care does a job? What is the type you expect out of modern medical care? So how do you suggest your patient to go for Ayurvedic or other alternative medicine when he comes with arthritis? Surprisingly, that has been published in our Indian Rheumatology Association, JAPI. In that, what it was surprised and was paining for me was more than 60% of the MBBS qualified doctors committed on their sheets clearly that they refer their patient to an alternative care medicine when he comes with arthritis after 3 weeks of treatment. So in a sense that made my point clear that yes, amongst ourselves, the information about arthritis care at that point of time in 1997 was not adequate. So then I took up as a mission, I actually pulled on Dr. Dharmanand, and I pulled on as many rheumatologists we had. We almost went on doing lots of CMEs, trying to tell them time and again, this is the way to handle it, this is the way to manage it, this is how it has to go about, this is what it makes a difference, this is how it makes a difference. I now have a itch to go for this particular review again, to sending back to all the general practitioners again and to find out, are we still in the same point or has it really changed? But definitely as I could see, I think even Dharmanand will agree with me that the type of patients which used to be referred for us at 97 and 98 and now make a very big difference. In 97, out of 10 patients referred, 5 to 6 had a deformities. Now, out of 10 who are referred, only 1 or 2 patients have the deformities. That makes point clear that yes, there is a lot change difference which has come. And in addition, the prescription pattern also has changed from the referring doctors. Usually a referring doctor has by now had tried either a sulfasalazine or hydroxychloroquine. Maybe few have added methotrexate, few have not added methotrexate, and that change has come. In a sense, there is a tendency to introduce disease-modifying anti-rheumatic drug. That's a welcomeable change. But there are a few small areas which we need to work out. Hopefully, the times we have, we should be able to achieve those targets. Thank you very much. I think I have a small announcement before. Please don't move after the closure of this. There are few more fun after that. I think there are few pharmaceuticals have some sponsored prizes. I think 3 of them have, one have a lucky dip. I think one a question of the day is there. I think one more has a lucky dip. 3 of the pharmaceutical have some prizes to be given.
Can I ask a small question to Dr. Pandya, who has come all the way from Gujarat? You have come all the way from Gujarat. Thank you so much. I saw in the television recently our Narendra Modi is down with H1N1. We are all admirers of Narendra Modi. I just want to know what is his state of health and how is he doing now?
No, not just Narendra Modi. Even one of the speaker, Dr. V.S. Negi has H1N1. He's doing okay now.
He's absolutely fine.
That's the reason he couldn't come.
He was always, he probably has a lucky gene, so he does. And the doctor treating was actually just sits, we are in the same building, so he was in charge of him, and he had a humorous way of dealing with it. That is what I was told. I've never met him.
Was he hospitalized?
No. He was just quarantined. And some of his secretaries also got in with H1N1 because they are.
Yeah, I think before that, give the momentum.
Anyway, thank you very much for a very interactive session.